Hello, everyone. Thanks for being here. I'm going to talk a little bit about Pain Care BC. We're different from Pain BC. We always get confused with each other, although we do work very closely together. So I'm going to start off with explaining what Pain Care BC is. So first of all, why are we here, and why does pain matter? Pain is everywhere and nowhere, we kind of say on our team. It's across all levels of care. It touches many disease populations, but it's also sometimes hard to find and define. We don't have services defined at every level of care for pain. But it actually is 1 in 5, even in the pediatric population. So I'm going to say that again because I have lots of these discussions. 1 in 5 kids has chronic pain as well. And I think that's really important to just think about and recognize. And often it's not diagnosed because we're not aware of what it is, but it's those frequent tummy aches, those many days missed of school, those inability to engage in activities and sports, and then later on down the road they become our adults with chronic pain. So we know that untreated pain leads to worse health outcomes and lots of socioeconomic burden. We know all of this information, I don't need to go into it. But pain is also very highly linked to the overdose crisis. And from a lot of our work, we've been recognizing that pain education for healthcare professionals is lacking across all disciplines, both within school when we're in our pre-licensure programs, and also post-graduation. So what do we hear from patients? We hear that chronic pain is often invisible. It's leading to lots of disbelief. Can I take this off and walk? Oh, I like to move. Okay. Leading to lots of disbelief and stigma for pain. Oh, see, I move a lot. Gary knows this. We know that chronic pain is often invisible. We have significant gaps in timely and appropriate care, and we have poor public awareness of chronic pain and what's going on in pain. So our hope really through Pain Care BC is start to work on consistent timely access, have some more evidence-informed training for clinicians, and work on patient-centered pain care. So I like some of these quotes from patients that we have. I spent years waiting to see a specialist. I assumed they would fix my pain. We've heard this before, probably. In that time, I just spiraled into a dark place. I became worse and worse until eventually my quality of life was taken away from me. When I got to the clinic, I started to learn about pain and self-management. I wish I knew about this right away. It would have changed my life and changed my pain. And we hear this from so many patients. They're in the system, they're jumping from clinician to clinician, and then eventually they're put on a list to see a specialist for chronic pain, and then it's not until they get there that they start to actually learn about what chronic pain is. And we know from all of our engagement with patients and with clinicians that the tertiary centers is not the place for them to learn about pain. It's not where they should start understanding what pain is and start learning about self-management. They need to start learning about it from the get-go if they want to be successful when they eventually get to that tertiary level of care. It needs to start in the community and it needs to start in primary care. I stumbled upon the information in researching what I was experiencing, but I was never provided any guidance or information from the 15 medical professionals that I saw. This is from one of the studies that I'm involved in where we engaged with patients and clinicians to understand their understanding of biopsychosocial models of care and understanding of what pain was. And it was shown in most of the research that most of them didn't know that they had chronic pain or what it was until years later. What we hear from clinicians, and I've been here as well, I feel so isolated, overwhelmed, and exhausted. Everything I knew wasn't working, but I didn't know what else to do. I felt like everything was a gap. I didn't even know what a gap was. Medicine is taught by breaking the human down into systems, but it never puts them back together again. We engaged with multiple clinicians across the province to understand what their barriers and challenges were when working with pain, what their gaps in knowledge were, and where they wanted us to go as a province. And it was really interesting. Even the clinicians that were put into the tertiary clinics, these specialized pain centers, were kind of dropped in with no training, with no mentorship, and no education in pain. We're all here because we care and we want to do a good job, but we also don't have the tools to do that when we're working with pain. So what we're working on as Pain Care BC, we're a provincial body, we're a health improvement network, and we're working on integrated, equitable, and sustainable pain care systems with access for all, evidence-based care, and prevention and early intervention. So what is a health improvement network? Because I also didn't know, and I'm sure many of you don't know. We have multiple health improvement networks within our province: Cystic Fibrosis BC, Emergency Services BC, and it's essentially a group of individuals that are brought together for a disease population to work on coordinating care on a provincial level. So we have purposely coordinated partnerships where we bring together networks of experts working across health authorities to identify data-driven system needs. We lead provincial quality improvements to translate evidence into practice, implement KT, guidelines, educations, care models, and support system-wide service planning to help with context for analysis, implementation, and change management. Now that's a lot, and we are a small team. This is what health improvement networks do in general, and this is what we're working towards on our team for pain. So the impact of HINs, there's some HINs that have been around for about 20 years, and we are a newer one. So we've seen that HINs are able to help align the system with common priorities, able to reduce duplication of efforts, siloed planning, and inefficient use of resources, and help to improve care quality and enable cost savings to the health system. So this is our team, our small but mighty team for Pain Care BC, and really we're working towards ensuring people can access pain care services that they need at the right time, at the right place, and with the right provider, because right now that's not happening. And our network is focused on transitional to chronic pain across the lifespan. This is a very busy slide. This is our strategic action plan. Just the key areas that we're focusing on over the next couple of years. So for the first area is working on equitable care access for all. So some of our deliverables, and I'm not going to go into all of them, but looking at stepped care and models of care, rapid access low back pain, which some of people in Fraser Health are probably aware of, looking at neuromodulation planning, and Gary can speak more about that if you have questions. He's your neuromodulation go-to. Working on enhancing capacity of healthcare professionals working in pain. That's what I'm focused on. So I'm working on setting competency standards for allied health and nursing for chronic pain in our province. I have a working group together, then we're hoping to complete that work in the next year. Promoting evidence-based practices to minimize variations, so we're working on tiers of service. We also have a pain research network in our province for pain as well that I'm leading, where we bring together researchers in various areas of pain and connect them with our clinical networks. Evaluating patient outcomes and understanding how care impacts patient functioning, so looking at provincial pain data, analytics and insights, data standardization, setting standards for what our benchmark should be when we're working with chronic pain populations, and improving awareness about the impact of pain in individuals and the health system. And a lot of that work is in collaboration with Pain BC. So how can we help? And what can we do for you? We can act as a consultant or an advisor for your team, okay? So we can help connect you to pain education, clinical tools, pathways, and resources. We have a lot of connections and we like to make use of them. We can link you with key partners like Pain Canada, other health authorities, the ministry, other people that might want to start programs that you want to do, or other people that might have already completed programs that you want to bring into some of your clinics. So we can connect you with other primary care sites that are doing similar work. There's a lot of primary care networks right now that are wanting to focus more on chronic pain services, and a few of them have decided to specifically focus on chronic pain with their allied health team that they have connected to the clinic. So we've kind of come in and helped them get that service up and going, train their team, integrate the service into a multi-disc setting. We can also support implementation of team-based care, biopsychosocial models of care, and person-centered care as it relates to pain, and offer access to provincial clinical networks for allied health and nursing, which is the next slide. So we have a provincial network that we run. We meet monthly. It's for allied health and nursing, maybe a physician one down the road, led by Gary. I keep calling him out in this one. So if you have any clinicians that you work with that are wanting to learn more about pain, anybody can join. It's across tertiary level all the way down to private practice. We have over 100 members right now. We meet monthly. We rotate through various topics, whether it's a clinical education topic, whether we pair a researcher with a clinician, or we have a psychosocial community of practice where we talk about implementing psychosocial models of care into practice. If anyone's interested, you can send me an email and I will help them get involved. Thank you. That's all I have. define what we're calling chronic pain. Well, technically, through the International Association for the Study of Pain, it's any pain that's been lasting between 3 to 6 months and more. So that's kind of the transitional time would be like the 3 to 6 months, and then after that, it's chronic.
So we're talking about pain when the source of the pain is gone, and it's become a biopsychosocial condition, and it's not purely a physical condition anymore.
That's a type of pain. So we typically have 3 types of pain conditions. We have our nociceptive pain, which would be the type of mechanical pain. I've got an injury to this muscle, to that nerve, and that's our typical low back MSK pain. Then we have nocioplastic pain, which is more of our general widespread pain, and we can't always find the mechanical cause for that, and it's more due to central and peripheral sensitization and the mechanisms at play. Those would be like our fibromyalgias, our widespread pain. And then we have our neuropathic pain, which is due to, follows the neuroanatomical correct pattern, and it's due to an injury of a nerve, and those would be more like our CRPSs, and another one's slipping my mind right now. Peripheral diabetic neuropathy, yes. So all of those are chronic pain. So any type of pain that is lasting past that 3 to 6 month mark is considered chronic pain. And it can be episodic, it can be daily, it's just, it's continuous pain that's happening. Any other questions?
We have one here on Slido.
Okay.
How can clients be connected with your services?
Good question. So we support the clinicians more than the patients. So Gregg is going to come up and talk about all of the patient services for chronic pain. We are more supporting the clinician side. So we run the networks, the education, setting the clinical standards and the competencies. So we don't engage directly with patients. We sometimes are involved in research related to patient care, but the patient side of care is more Pain BC.
Okay, so thank you so much, April, and it's a pleasure being here. I'll be presenting on Pain BC's resources and programs for practitioners and for people who live with chronic pain, all of which are available to anyone in British Columbia for free. If you pull out your phone and scan this QR code, you'll be able to download a quick reference one-pager. One side is all of our programs and resources for physicians and other practitioners, and on the other side is all of our programs for patients. And there's hyperlinks for each one, and I'll put this up at the end of my presentation as well. I just want to acknowledge that Pain BC's offices are located on the unceded ancestral territories of the Musqueam, Squamish, and Tsleil-Waututh nations. And Pain BC was founded 17 years ago. It's now the world's largest nonprofit, providing evidence-based and trauma and violence-informed resources and programs for people who live with pain and the healthcare providers who care for and support them. Many of our programs are funded by the Government of BC and our Health Canada-funded Pain Canada initiative, and several are now, through that Pain Canada initiative, several of our programs are offered across the country. So I'm going to start with an overview of our programs and resources for healthcare providers. Then I'll move on to the programs for people who live with pain. To access our programs for healthcare providers, up at the top of, this is a screen cap of our website, and at the top you see health professionals. If you go on to painbc.ca and click on health professionals or hover your mouse over that menu item, it will take you to all of the programs and resources for people like you. So all of our educational programming is developed by our education team, working with subject matter experts from multiple disciplines and people who live with pain. We've got a continuum of programs for healthcare providers, starting with improving baseline understanding of chronic pain and approaching patient care with an evidence-based trauma and violence-informed approach, and that biopsychosocial model of pain. I'll start with the first level through and of our programming and then move up to deeper, more complex, and more individualized learning opportunities. So the first one is Pain Foundations. It's offered through online self-paced modules. A Pain Canada certificate gets issued after you complete the 3 basic modules and after each of the advanced modules. You don't need to take all, excuse me, you don't need to take the advanced modules in order, with the exception of the capstone module. So you have to have completed all of the others before doing the capstone module, which explores case studies through 3 different provider perspectives: psychosocial professionals, manual therapy professionals, and medical professionals. We're currently working on a new module on sexuality, gender, and pain that is going to be released probably in November. This is just to give you a little example of some of the content covered in a couple of the advanced modules you can see on the left-hand side of the screen. And on the right is a screenshot of a case study of a trans man who's developed neuropathic pain after surgery to repair multiple fractures from a workplace accident. None of our, You're not going to get bored with any of our education programs that are online. It's not screen after screen of text. There's lots of interactive things, case studies, videos, and so on. Chronic Pain Insights is a 3-module course specifically to support healthcare providers working in perioperative contexts. All of our online training, like I mentioned, is really interactive. You can see in the top corner in really teeny tiny print is the word resources. On all of the screens in our self-paced learning, there's resources. So if you want to do a deeper dive into any of the topic that happens to be on your screen at the time, you'll be able to click there and get to more materials. Our Moving Through Pain course equips healthcare providers with practical knowledge and teaching resources to support people living with pain to engage in gentle movement and relaxation as part of a supported self-management plan. The course takes about 4 hours to complete. It's mostly done by physiotherapists, RMTs, OTs, nurses, folks like that. With support of Doctors of BC and Shared Care, we're delivering 10 chronic pain education sessions a year for 3 years to divisions of family practice around the province. And they're delivered by MDs, NPs, allied health practitioners, and staff members like myself who have expertise in topics that are relevant and chosen by the members of the division. So if you think of particular topics related to chronic pain you'd like to know more about, just connect with folks at the division. They'll work with me and we'll pull together a session for you. I've got a snooze and alert that's come on the screen here. Doctors of BC Shared Care has been supporting the BC Echo for chronic pain since 2019. We're currently delivering our 11th cycle, and it's comprised of 4 monthly lunchtime sessions on chronic pelvic pain. Registrations are currently closed, but they're going to open up soon for cycle 12, which runs February through May. The Echo Hub team is comprised of healthcare providers with expert knowledge in chronic pain, and they design the Echo sessions and facilitate them. They present instructive lessons and provide personalized recommendations to the case presenters. Even if you don't register for the Echo, you can still apply to access the library of didactic presentations, and that's a really valuable resource. You just go to the Echo page, it's painbc.ca/echo, and click to register there, and you'll be able to access that library. The BCAMN launched 4 years ago with funding from Health Canada's Substance Use and Addiction Program, and it's currently funded by Shared Care as well. The QR code will take you to the BCAMN webpage where you can learn more and apply to become a mentee. We do quarterly intakes, so the next one's coming up in January. The Adaptive Mentorship Network is based on a model that has been used in Ontario and Nova Scotia for many years. At the core of the network are small multidisciplinary groups, and they're facilitated by specialists in at least one of the areas of pain, mental health, and substance use. 2 of our mentors are right here, Gary and Tori. And the groups meet once a month, most months of the year. There's also an annual BCAMN Summit that is coming up in November. The small groups, in the monthly meetings, there can be case studies, there can be specific didactic presentations on topics, but after each of those full group sessions, they break out into the small groups with their 4 mentors. And those are meant to be really safe spaces. So you can talk about things like your feelings of imposter syndrome, how to manage conflicts at work. And if 5 people in the small group are dealing with family breakups, or they're on the verge of family breakups because of work-life imbalance, then that's what the group is going to talk about. So here you see a list of all the mentors in the group. Any mentee can also request one-on-one time with any of the mentors. The clinical director is Sean Ebert. He's a pain-focused family physician who practiced in Vanderhoof for many years before moving to Coldstream a couple of years ago. It's a really special group of people with deep knowledge and incredible passion for supporting other clinicians. Like I said, you can apply anytime, and the next quarterly intake is in January. So now I'm going to shift gears and talk about our patient-facing programs and resources. We offer 3 online opportunities for self-directed pain education, 2 programs that provide group learning, and 2 opportunities for one-on-one learning and support. So like our programs for practitioners, all that we offer for people who live with pain is free. So this first program is Live Plan B Plus. I can never get that out of my mouth the first attempt. It's a highly interactive online learning program that focuses on encouraging patients to make small changes to improve their well-being. You can see just a few of the topics listed here. Excuse me, there's a great breadth and depth of content in Live Plan B Plus. Some pain clinics refer their patients to Live Plan B Plus while they're on their wait list. So they can either tell them, hey, I want you to start on this module and this module, and then you're free to move into other topics that you might be interested in. Or there's an optional survey that patients can fill out at the beginning, and the logarithm or the algorithm will direct them to topics that fit their needs and interests. Oops, I've got a notice here that our program is on. There we go. So it's also something that you can offer to your own patients when you've referred them to specialists. For instance, the Comox Valley Nursing Center pain program, once they started referring people to Live Plan B Plus on their wait list, they started finding them coming in for their first session saying, okay, that's not my concern now. I'm doing much better on that because of what I've learned on Live Plan B Plus. So can you work with me on these other things that that are my high priorities now? So again, it's highly interactive with videos, drag and drop quizzes, opportunities for users to take notes in an online diary as they plan the small changes they intend to make and make progress towards them. Gentle Movement at Home is a library of 37 YouTube sessions for guided movement and relaxation. They're done by PTs and other therapeutic movement professionals designed to help people with persistent pain learn to feel safe to move again. Because anxiety and fear about movement is something that's very common amongst us folks who live with chronic pain. Each session lasts about an hour, and they cover topics like breath work, breath awareness and regulation, body tension regulation, and movement and relaxation techniques in sitting and standing positions. Evidence shows that learning about pain before their operation helps people undergoing surgery set realistic expectations about pain, use their prescribed medications more accurately and safely, and improves their well-being and comfort. So each self-paced module of managing pain before and after surgery is about 30 to 45 minutes. Participants can also choose to enter into a Pain Canada research study to see how the education program is changing how much pain medication they require and how it affects things like their anxiety and level of pain they feel post-op. The first of our group learning supports is Making Sense of Pain, like April mentioned. It was designed specifically for people who experience marginalization, and we piloted it in Vancouver's downtown east side in 2018, and they are on their 12th or 13th cohort at this point. It's currently offered in person and online across BC, 6 or 7 other provinces, and Yukon Territory. For people who live with pain in BC who don't have an MSOP program in their area, Pain BC Support Services offers it 8 times a year, delivered by our social workers and clinical counselors. The evaluation and feedback is very strong. We continually update the program to respond to the feedback both from participants and from facilitators, and we do a 3-year cycle of reviewing the literature to make sure that we're updating the content to be up with the latest science. Funding for MSOP is provided by the Government of BC and the Sovereign Order of St. John of Jerusalem Knights Hospitalier. Our other group learning and support program is Pain Support and Wellness Groups. There are 6 regional groups, and the one that covers this Surrey-North Delta would be the Vancouver region group that's highlighted in blue there, and there are actually 2 of them because we cap them at 15 participants. There are also 5 province-wide groups for LGBTQ+ adults, young adults, members of the BIPOC communities, Punjabi speakers, and Mandarin speakers. After introductions and a brief check-in during each of the sessions, there is a presentation and educational materials are provided afterwards. We didn't want the support groups to become bitch sessions like a lot of support groups can become. So there's curriculum and people continue to learn. One of our clinical counselors has been certified to offer empowered relief, which was developed at Stanford. It's open to anyone across Canada, and it's delivered monthly. It's a 2-hour session online. Retention in the sessions is over 90%, which is pretty unheard of for a 2-hour Zoom session. And participants also receive a free binaural relaxation audio file that they can download. One of the most frequent encounters with Pain BC is through our pain support line. Last year, we logged over 2,000 calls with our social workers and clinical counselor who staff the line, and they provide information and emotional support to empower people who live with pain and the loved ones who care for them. Requests range everything from helping to find a healthcare provider when someone's moved to a new city, people seeking information about income supports, and of course, emotional support. And healthcare providers can call the pain support line too. And Tracy will be showing you how you can access that and other of our services through the Chronic Pain Care Path on Pathways. Last year, the volunteer coaches in our Coaching for Health program helped 104 clients over 661 sessions. The volunteers get over 40 hours of training before being matched with clients who get up to 12 weeks of one-to-one coaching, and it's done online through Zoom or by phone. Placement in the program is made by referral from registered healthcare professionals for patients who are 18 or older. You must be an adult to access Coaching for Health. They have to have chronic pain that's interfering with their daily function, and they have to desire change but feel like they're hitting a brick wall or they're not sure what to do to progress. So they have to have some desire in self-management and making change. Patients who don't have a care provider can call our pain support line and be assessed by one of our social workers. But as I mentioned, you can also refer patients directly through Pathways. We've got 6 rack brochures about our programs and services that are free for practitioners to order from our website. We'll ship them directly to your office, whether you'd like 10 of each or 50 of one and 2 of another. We'll send them right to you. It doesn't cost you anything. We also have bookmarks promoting the Managing Pain Before and After Surgery program. So you can reach out to me afterwards. You can either email or text me, or you can just go to our website and go to painbc.ca/brochures, and that will take you to them. We also have more than 30 fact sheets on topics in 7 languages. All of our programs and resources and information sheets that are available in Arabic, simplified Chinese, traditional Chinese, French and Punjabi and Spanish are centralized in these language-specific resource hubs on our website. If you go to painbc.ca, find help/multilingual, you can refer patients to that link and they won't have to weed through the English content on our website to find materials in their own language. And this is just a screenshot to give you an example of a homepage for the site for people who read simplified Chinese. So they get the same graphics and everything that are on our English website, but they find things in their own language. And here's my contact information. It's easy. It's Gregg with 2 G's at painbc.ca, and my phone number 604-961-6556. I'll put a bunch of my cards on the resource table at the back of the room. You're happy to take them. Reach out to me at any time, and this is the QR code again if you'd like to download that quick reference sheet.
We've got time for some questions for Gregg, so we'll let you go.
Are there Main Pro credits for courses completed on the BC website?
We have in the past provided Main Pro Plus credits for right now. I think it's only available for the BC Echo for chronic pain. That's Main Pro Plus accredited. We used to have accreditation for pain foundations, but we've updated the curriculum and we're creating some 2 new modules. Like I said, the one on sex and gender will be out this fall. And so once we finish all of those, we'll be submitting that for Main Pro Plus accreditation as well. And you can, of course, always apply for your open hours. So if you're attending BCAMN meetings, for instance, you can record those and submit those for your self-study.
Does anyone else have any questions for Gregg? Please feel free to raise your hand or input them in the slide. Otherwise, we have one more question for Tori. Can you please clarify what chronic pain is?
So yes, realizing now maybe back up would be good. As if there is interest in a session on what chronic pain is, kind of what happens to our nervous system once we have pain in, or what is the different types of pain that we present with, I'd be more than happy to go through that in a future time. Got making those lectures down. Chronic pain is any pain that persists longer than that 3-month range. I'll say 3, even though 3 to 6. There's some debate in the literature. Any pain that persists longer than 3 months. And sometimes we can find cause, and sometimes we can't find a cause to the pain. And I think the more challenging patients that come to you are the ones where we can't find a cause, we can't find a fix, we don't have medication that's gonna, they go away, but they can still have that pain. And we know from the research that when pain persists, our nervous system changes. And our nervous system starts to become hypervigilant and hyperresponsive and hyperactive. And what the brain is responding to as messages that the brain are getting about danger and pain start to just rapid fire up. And then the brain makes the conclusion, well, there must be something wrong with our body, so I'm gonna have a lot of pain. And when we say, well, it's psychosocial pain or it's mechanical pain and all the words that we have related to pain, sometimes it doesn't really matter because all of them are little check boxes that tick off in the brain, creating the pain experience. So pain is the experience created in the brain. It's not the output of a tissue. We don't have pain receptors. We have nociceptors, danger receptors, but pain is interpreted in the brain. It's a decision made upon the brain based on multiple factors, which is why we have to assess and treat it holistically. We have to look at mood, we have to look at movement, we have to look at beliefs, fears, understanding. But first and foremost, from all of our patients, we hear that we need to start with validation of their experience. It's not in their head. They're not crazy. Their pain is real. They're sitting in front of you. It's a 10 out of 10. They look fine. It's a 10 out of 10. You tell me, okay, it's a 10 out of 10. It's a 10 out of 10. So breaking down some of those boundaries, validating their experience, and kind of finding a way into a lot of the supports that Gregg has mentioned is one of the best first places to start with chronic pain. And there's so much they could do at the community level, and not all people with pain need to go to a tertiary pain center. And I think that's a huge problem that we're having in our province right now is everybody gets referred up and everyone's on a wait list for 3 years And then when they get there, most of them don't need to be there. Because from an interventional and pharmacological standpoint, we don't need those interventions for all days of pain.
I'll just add, as a person who lives with chronic pain, I had back surgery when I was 15. My scoliosis is a nice S shape, so I've got musculoskeletal pain. I've got rheumatoid arthritis. People who live with chronic pain, who know that they live with chronic pain, it's interfering with their daily lives. A lot of people who live with chronic pain have no idea that they do. We have people who come to us all the time, and especially with things like the Making Sense of Pain program, when people are recruiting for their program, in some cases they're in, inner city community centers and things like that, and they're talking to people and they say, it's for people who have chronic pain, and the group of folks they're talking to go, well, I don't know anyone, and you say, well, how do you sleep at night? Oh, I haven't had a good night's sleep since I was in my 20s because I wrecked my shoulder in a car accident, and I haven't been able to sleep more than 3 or 4 hours at a time since. That person often has no idea that they're living with chronic pain. And so part of the education process is teaching them, hey, you live with chronic pain, but there are things you can do to help. And part of the thing that I'm really passionate about, because I came from a family where there were lots of physicians and chiropractors and teachers and ministers. And so my family took a holistic approach to pain. Family physicians don't have to feel like they need to know all the answers and have all the solutions. That's, you folks all know the stress that comes with that burden you place on yourselves. Part of the education from our programs, both from the Adaptive Mentorship Network, through the ECHO, and through Pain Foundations, is to teach healthcare practitioners, hey, these are the sorts of things that this profession is really good at helping people with. These are types of treatment modalities that work really well for these types of people. And for most of us who live with chronic pain, it takes a village. So for me, it's the stuff I do for myself, my physiotherapist. When things get really bad, I'm going to physio. The rest of the time, if I'm doing my chiro and RMT once a month, I can keep things in check. And that's, from talking to other people with chronic pain, that's very typical amongst us. It gets tougher for people who don't have good healthcare coverage. And so that's where things like our Making Sense of Pain program and the pain support and wellness groups and the support line and coaching really play a much more important role, because if I don't have access to a massage therapist or a chiropractor or a PT, I need to learn all that I can to put everything I can into my toolkit to manage myself better. Yeah.
So I'm a family doctor, somebody's involved in an APA, they land up at a physio.
He says you need 24 sessions every week for the next 24 weeks. And then at the end of that, they say, well, you haven't had enough, give me more. There's done the doctor. I say, no, you have chronic pain. You need to go to the ABC website and read this and read that. They say, no, I used to do that. From the physio and the chiro and the RFT keep telling me I need to come back every week and ICDC. How do we rate that side?
Yes, I'm working on this, UPS. When I see patients with chronic K2, it's the same thing, and I think it's part is building that rapport on that trust and having that conversation. Well, how do you feel after you come back with those physio sessions? Is your knee gone? Are you getting what you need out of those sessions? Because it sounds like you're still having pain, and I wonder if this is the best path for you. I wonder if we should try something else. And it's a lot of them kind of getting them to self-reflect on that. Well, you've been doing this and you're not getting the outcome that you want. So we need to try something new. We need to try something different. And getting them to understand pain, like little snippets. I think one of the best ones that I use with patients is, sometimes we have pain and there's nothing going on in our tissues. And sometimes there is nothing going on in the tissues. We don't really know, because I don't have a microscope to look deep down in your muscles right now and see what's going on. But what we do know is that if pain persists, our nervous system changes. Has everyone seen a car alarm in a parking lot, going off, and you look over and there's nobody there? Of course, it comes over, they shut the car alarm off, and then somebody goes by with one of those loud buggies and the alarm goes off again. Has anybody seen that before? Why is that alarm going off? Should it be going off? Is anybody breaking into the car? No, that alarm is hypersensitive, hypervigilant, and it's responding when it shouldn't be. And that's exactly what our nervous system starts to do when we have chronic pain. It's the same thing as, we go into the shower with a sunburn, it really hurts. Is the hot water hurting our skin? No, our system has changed, our skin has become hypersensitive and hypervigilant, and it's telling you that that's dangerous. So we get messages from our body, and it's our job to determine if they're true or if they're safe or if they're dangerous. And our brain is going to conclude more likely that it's dangerous and more likely that we're going to have pain, because that's his job. His job is to keep us safe. And our job is to start, questioning some of those decisions that it's making and providing resources and providing safety and teaching the body how to move with less pain.
Having the pain science conversation with your patients can be life-changing. We thought in Making Sense of Pain, the second session is about pain science. We thought it would go over like a lead balloon on the downtown east side, that people with significant mental health and substance use issues aren't going to care at all about this. Instead, the feedback we were getting was, oh my God, I finally understand what's going on in my body. So the question is about, if you didn't hear, the question is about the new med school being set up at SFU. What are we doing about getting more pain education into the university curricula? And Pain BC advocacy is one of the things that we do. We're so happy that we have Pain Care BC as well. I think it's still the case in Canada that veterinarians get more pain education than medical students.
Yeah, so 33% of your visits of primary care are related to chronic pain. That's huge. 10% of emerge visits are related to chronic pain. It's also insanely huge for the populations. We are working on that. We are very aware of that. I'm involved in a study right now where we're going across CAPTA, actually looking at all the different programs and seeing how much pain is being taught in each different discipline. And then we're eventually working on getting in there with education. But for physicians, it's very low for chronic pain. I just assessed the one at UDC right now, and I think it was 30 minutes on chronic MSK pain was all the program had. And if that's like 30% out of your population and you have 30 minutes of a lecture, how are you supposed to manage that?
And we're working on that nationally through Pain Canada. We have the National Advisory Committee, and we work closely with Health Canada, and we are trying to do our best to improve that across the country. Our advocacy with the government has always been based both on the financial costs of chronic pain, which are massive, through loss of work, like you were saying, as well as costs to the health system, but also with the overdose crisis, especially amongst trades workers. We've just launched a text version of the pain support line geared directly at trades workers. Actually, it launched this week. Trades workers have huge percentage of chronic pain, injuries, whether they're truckers or they're working in construction or the oil field or forestry. And a lot of them end up using illicit drugs because they're not managing their pain properly, and they end up overdosing, and a good percentage of them end up dying. And those are the kinds of arguments we're using.
Another thing is patients' expectation of pain relief.
And that's where the pain science education comes in as well, because like Tori was talking about calming the nervous system and learning techniques and pacing and things like that that will make your pain much more manageable and bring down, it's managing, it's lessening your experience of having the pain control you and putting you in control of the pain. So I know if I do certain things, I'm going to pay for it later, and I've got to decide whether or not it's worth it. But now I know enough to do that. I didn't before, and just ended up getting worse and worse.
Thank you very much, April, and thank you everybody for having me here. I am very happy to talk to you about Fraser Health Pain Services, resources and initiatives that we're working on to help chronic pain patients receive better care. So just as a reminder, there's the Slido QR code. If you want to scan it, we have a couple of polls questions. And the first question here is, the following pain services are in the Fraser Health Authority. So number 1 is the Jim Pattison Chronic Pain Program. Number 2, the Jim Pattison Pelvic Pain Clinic. Number 3, the Fraser Health Pain Self-Management Program. And then we have interventional pain clinics, or D, all of the above. Okay. The next one is, the Jim Pattison Chronic Pain Program's wait list is currently A, more than 2 years, B, approximately 2 years, C, 6 to 9 months, or D, less than 6 months. Okay, I'm just seeing the answers now. And so for this one, the answer is D. For the second one, we have a mix of answers. We have 30% at more than 2 years, 30% at approximately 2 years, and then around 33%, 6 to 9 months, and then nobody picked less than 6 months, which you guys are all correct. That it's not D. The actual answer is C, 6 to 9 months. So that is hopefully a pleasant surprise for most people. And then the last question that we have here is, who can send a referral to the Fraser Health Community Pain Self-Management Program? So we have A, only family practitioners and nurse practitioners and specialists, B, allied health working in Fraser Health, and C, A and B. And yeah, the answer is C, A and B. So that is kind of a good thing where allied health workers can also refer to the Fraser Health Community Pain Service, and I'll let you know what that is all about in a couple of slides. So before talking about our services and resources, I just wanted to highlight some key Fraser Health pain figures. So here we can see some modeled estimates based on BC-wide population data from 2021. While not exact counts, they provide a good snapshot of the likely burden of chronic pain in the region. So we can see about 387,000 people in Fraser Health have chronic pain, and about 5,000 of those work in our health authority. Those with chronic pain are 4 times more likely to suffer depression and anxiety, 2 times likely to have concurrent substance use disorder, and 2 times the suicide risk. So this also ends up being chronic pain patients having approximately 5 times more likely to visit a general practitioner on a frequent basis, which is more than 9 times a year if you have chronic pain. And about 200,000 of emergency visits in Fraser Health likely to be related to chronic pain. These numbers remind us that chronic pain affects so many people, and we want to figure out how we can increase awareness and access to care. I also wanted to point out some common barriers, some that I think we've discussed in the last little bit. There's a lot of stigma around pain, right? So pain is something that is invisible, and sometimes patients will not reach out and ask for help even if they need it. Like Gregg was saying, that some people have chronic pain and they don't even know that they have chronic pain, right? That is an issue. Pain is a subjective experience. It's also invisible, and so that makes it more difficult to assess and treat. There is a poor understanding of chronic pain, as Tori had outlined there. There's not a lot of education that is provided for healthcare providers and even for physicians, and so we need to do a better job of educating everybody. There's inadequate resources and long wait lists, so when people refer to programs, they may not know what they can do while they're waiting, and there's poor knowledge of resources available. So hopefully events like this can help us find out about what resources are available and refer patients to the right services at the right time. Okay, so our website has been streamlined. We just want to make sure that it is easy to access information that is accurate and easy to understand. So we have 3 different buckets here. We have the pain services, so we have a list of all the services that are available in Fraser Health. We have resources for patients, so all the resources that we recommend that patients use, such as Pain BC and Pathways. And we also have resources for healthcare providers, so evidence-based clinical information that you can use in your own practice. On the Fraser Health Pain Services site, there is also a pain services referral guide, just a nice, easy snapshot of the services available and how to refer to those services. And I'll be going through them here today. So you all know about the Jim Pattison Outpatient Care and Surgery Center. This also includes the Pelvic Pain Center. If conventional pain management strategies have not addressed pain adequately, you can refer to the Jim Pattison Center. They have multiple pain specialists and access to interventional procedures, as well as an interdisciplinary team that consists of occupational therapy, physiotherapy, social work, pharmacy, psychology, and nursing. Any of the patients that access this clinic can also attend an 8-week self-management program. And after they're done that, or in conjunction, they can also access specialized classes, which include gentle movement and relaxation, mindfulness, sleep, and a session on medications. The Community Pain Self-Management Program was formerly known as the Hubs, and I've been there since the beginning of the program. I'm very proud that I'm a part of it. We have an interdisciplinary team that consists of OT, PT, and nursing, and we teach the classes and provide individual consults. All the classes are now virtual, so the patients are able to learn, and they're able to learn from the comfort of their homes, right? They don't have to travel, they don't have to worry about parking, and most patients actually find that to be super convenient and works better considering their condition. In addition to the virtual classes, we also offer weekly health coaching calls. So if patients want to set goals or have any questions about the PowerPoints that we provide, they can do that with us one-on-one. We also provide case conferencing for patients that involves a pain specialist, a pharmacist, and our community team. So we decide if the patient can benefit from other services, and if it is applicable or necessary, we can streamline them to Jim Pattison as well. They also have access to pharmacy for consults and access to the specialized classes at Jim Pattison if needed. Something that has newly been added is that there is a patient navigator. So if your patient has been referred to the program, they will be called by a clinician, and the clinician will let them know what the service is all about and sign them up for the next cohort. That is happening pretty quickly, so the patient will get a call within a month, will be entered into a cohort if they're available within a few months. And if they can't join the classes for some reason, they don't have technology or they're not comfortable in groups, they can also work one-on-one with that patient navigator to learn about resources and self-management strategies. This is our agenda. So it's 8 weeks that we do the classes. They're 2 hours long. We decreased it from 2.5 hours based on the feedback that we received. And I won't go through all the topics here, but it is very well-rounded. We find that the patients who enter the program end up having better coping skills to deal with mental health. They end up increasing their activity and using pain management strategies. We also have alumni classes where patients can come back and connect back with us, which is actually pretty well attended. This handbook is also on our website, and there is a copy on the resource table if you're interested. There's also the interventional pain services throughout Fraser Health. So we have them at Burnaby Hospital, Royal Columbian, Langley Memorial Hospital, and Chilliwack General. And each clinic is individual, has their own referral form. So if it is an interventional need that you have, these are some places you can send your patients.
It is available in Jim Pattison also.
Jim Pattison? Yeah. Oh, sorry. So these are intervention only, whereas Jim Pattison does intervention as well as interdisciplinary care. There are a couple of primary care initiatives to help patients with chronic pain. So 2 that I wanted to point out is the Ridge Meadows Wellness Clinic. They provide education and have consults available as well as intervention. And then the White Rock South Surrey Primary Care Network also have education sessions run by nurses and pharmacists. They have introduction to chronic non-cancer pain, non-opioid medications, and opioid medications session. One of the other things that we are working on in Fraser Health is just increasing capacity for primary care to help patients with chronic pain. So I'm really happy to hear all the conversation that has been going on about chronic pain and how we have to work with patients at the primary care level as well as tertiary, as well as in the community. And one of the things that we're doing is a QI project that will focus on care team education, patient education, and service optimization. So hopefully, when we get things rolling, we'll be able to build the capacity for the care teams at the primary care level to help patients with chronic pain, educate the patients, and make sure that they have an understanding of how to refer patients appropriately. Okay. The last service I'll talk about is the opioid stewardship program. So for any patient that is being prescribed opioids, primary care providers may need some extra support. The opioid stewardship program supports with opioid selection, dose adjustment, rotation, tapering, and plans of management. They also do optimization of non-opioid pharmacotherapy for pain and provide advice about resources for pain management. They have live clinical support and on-site clinical services. It's available at RCH and SMH. This is the app that they created, so it's just a snippet of it. And through this app, you can see they have medications, pain management tools, patient resources, and an option to contact them. And you are able to talk directly to an opioid steward and get some support for your patients. A really good app. And they're saying that they're really underutilized right now, so if you have any questions, feel free to connect with them. Okay. If you just type in Fraser Health First Line Pain and Opioid Stewardship app, you'll be able to find it. There's a web version as well as an app that you can use.
So since most of the classes are virtual, do you have capacity of the patients, how many can enroll at the time? What is the main reason of such a long waiting list?
For
What the patients get in, like if it is virtual education?
Yeah. So the Fraser Health Self-Management Program, our wait list is 3 months. And that's because our cohorts are rolling, right? So like if you refer your patient now, they're not gonna get into the one that's already ongoing. They're gonna have to wait till the next one. Our capacity is 18 people or patients for the program because we want to get to know them. It's a relational program where we get to hear them and they get to hear other patients. So they really feel safe and supported in that environment, and they really also say that they don't feel alone anymore. So we want to keep those numbers small because we're not just talking at them. We're educating and having that. Exactly. Yeah.
You showed a slide with the interventional pain programs. What kinds of interventions are available?
So it varies depending on the site. And on Pathways, which Tracy's going to go through, you're going to be able to see a list of those interventions and the physicians that work there.
Jennifer, is the community pain self-management program offered in languages other than English?
Unfortunately, no. It is only offered in English right now, but Self-Management BC, we often refer to, they offer programs in Punjabi and Chinese. Pardon? There is no app?
No, it's antimicrobial, yes, but no opioid.
Oh, I don't. So just maybe type it into Google rather than the App Store.
There is no selection opioid.
I'll show it to you in Pathways, and actually you can send a question to these the pharmacist, which I've done through Pathways. But it is not on the App Store.
Yeah, not on the App Store, sorry. It's on, if you just look it up on Google, you'll find it. It's a website or an application that is on the internet, not an app through the App Store.
This could be for any of our presenters. What are your thoughts on a realistic approach to chronic pain in terms of how to explain to patients?
You can go ahead.
Yeah, there's a lot of really good questions coming in, and I'm happy to answer them after. I feel like when we're working with chronic pain, we always want to start with obviously clearing red flags, any concerning issues that we think there might be going on. But if it just seems like it's constant pain, I would start with self-management and start with teaching them about pain, getting them to understand what's going on, hurt versus harm. And then I guess, Gary, maybe you can take, when would you refer up to an interventional clinic? Because there's some questions coming in on that as well. These are all big questions. These are our systemic issue questions. Do you want to come to the mic, Gary? Gary's our pain specialist. So when would you consider keeping them at the community level versus referring up to interventional medicine?
So once you've exhausted all conservative strategy, pharmacological strategies, then consider referral not necessarily to an interventional clinic, but to a pain clinic. So pain physicians will have expertise, hopefully, in the management of pain, other than sticking needles into people and offering the cortisone injections. And so, like I said, so once conservative strategies have been tried, once you've tried self-management, once you've tried pharmacological therapies, then I would consider a referral to a tertiary pain clinic.
My question is that when patient is coming with me, so what is the goal? 100% improvement, 20% improvement, 70% improvement. That is what I want a clarification that how to tell the patient that it is not going to be 100% cure. We agree on that.
So I think that's a fair statement. You would just say that there's not going to be 100%, but I don't know if they're going to get 20% better. I don't know if they're going to get 50%. So even in my own practice, with the interventions and treatment that I offer patients, I don't guarantee them any success of 100% table. What I say, I will try to reduce your pain, but I don't know by how much I'm going to be able to do that.
And rehab should be coming in also not promising to make pain go away. Our goal is function and quality of life. So the pain may remain, the pain may come down, but our goal is for them to have control of their pain rather than their pain controlling them, to reduce flare-ups, to understand what's triggering their flare-ups so that they can manage, and to learn some strategies to calm the nervous system down and calm the pain down. And if in all of that, the pain comes down as well overall, fantastic. But our goal is really to be able to do more and function better with pain. And that's a hard thing for people to accept and digest. And it's a very difficult conversation, but it gives hope because you can live well with chronic pain.
For background, like half of my practice, I have my own community pain clinic in Abbotsford, so Initium Center for Pain Medicine. And then the other half of the week, I work in Prince George at the UHMBC Pain Clinic. When I was a trainee in Ontario, we had a lot of referrals for MAID, and specifically for the reason of chronic pain. Majority of those people, at least the assessments that I was a part of, once you had adequate pain control on board, most people didn't opt for MAID. And so I was going to say, I don't know what's going on now, but in the last 6 years, I think I've only had maybe 2 referrals sent to me for MAID. I think there's some data to show that since 2018, people have been less likely to prescribe opioids for people with chronic non-cancer pain, even palliative pain. We've seen a reduction in the number of opioids being prescribed for people that are suffering. We are working with different ministerial levels and people in government to try and address that. But yeah, I think I don't want to say loosen the reins, but I think being a little bit more generous with those MAID patients with chronic pain, I think we'll see a difference in the referrals coming in. Hopefully that addressed your answer. Okay.
So hopefully all of you who are here have a Pathways login and have your own individual login.
And if you don't have a Pathways login, or if you're using a clinic-wide login, today's the day to switch your login to be your own individual account so that you can start saving your own favorites and saving your own email bundles and things that I'm going to be showing you. So if you don't have your own account or any account, go to pathwaysbc.ca and hit Request Access and explain that you want your own login. So pathwaysbc.ca and select Request Access, and hopefully all of you here already have an account. I'm going to point out that Pathways, there's two main ways to navigate it. And I get surprised sometimes by how many people have missed this great big blue button, and they're just using the search. So first off, I'll point out with search, if you do use it, you'll often get really overwhelming results. Like if I type something like diabetes, oh my God, too much stuff. But notice there's this filter my search. So did I write diabetes because it's my reason for referral? If that's the case, notice I hit reason for referral as my filter here. And so now I have a choice of consultants and wait times for diabetes. And if I click this, I'm going to get to a list of consultants and their wait times for diabetes. Or maybe I was looking for these purple health authority and community services programs for diabetes education. Maybe I wrote diabetes in the search because I was looking for clinician tools. So here I can hit clinician tools and notice that there's some of these that are favorites on the site, they're Pathways picks. And for example, I use this one all the time, medication selection for type 2 diabetes. You know, you got the patient who's already on 2 meds. What am I going to pick for the third? I use that interactive tool. Maybe I put diabetes in because I want patient info. So I hit the patient info filter. Or maybe I'm looking for something somewhere else in the province, like I have a patient who moved somewhere else. So sometimes you're going to need to use this whole province button. So that's a little bit of tips about using the search. But what I really want to point out today is this big blue select specialty or service button is definitely your friend. And in this case, we would hit the specialty of pain medicine. So notice when you hit the specialty of pain medicine, it takes you by default to the tab of consultants. And it shows you the different wait times for individual consultants. And here as well, you can see there's all those different things that you could send a patient for. These are the potential reasons for referral. And maybe it came up earlier, you're sending for some kind of procedural pain medicine. And maybe you're looking for specific kinds of injections. So if you were looking for specific kinds of injections, are you looking for a joint injection? Are you looking for interventional pain procedures? There's barbotage, neurolytic procedures, and the ones with the asterisks, a person providing them has to have procedural pain medicine certification. So there's certain things that you can search for. Also remember, if you scroll down further, there's a language filter. So maybe you need a pain consultant who speaks a particular language. Maybe you need a Hindi-speaking pain consultant, so you can hit Hindi in the languages. Maybe the gender of the consultant matters to your patient, so we can open that, and maybe it's a man who only wants to see a man, so we've got some options there. Maybe it's a patient who is frail, and for whatever reason, we're going to look for virtual care services. So notice that there's a virtual care filter that you can open up and see if anybody would do a virtual care consultation. So you see some of them are. And let's just look at these symbols. The green check mark, accepting referrals. The phone means they do virtual care by phone. The video means they do it by video. This symbol means a pooled intake. Some are taking e-referrals through Pathways. So let's just clear all the filters. Notice as well, you can hit the show details, and it gives you a little bit more detail about what the consultant may or may not like to do. So notice as well, across the top, there's all these other tabs. Like, don't get trapped in just the consultants. There's the clinics and pooled intakes. there's advice, and this is a really important one that I wanted to show you guys. So here's that pharmacist pain management advice. Those are the people behind that app, and to be honest, it's just way faster to send them a question than it is to try to use that app, I found. So if you wanted to send them a message, any of the services that are taking a message through Pathways have this symbol. You could hit that, or you could open up the program, and you see you can send them a message through Pathways, and it explains they're the opioid stewardship program run by clinical pharmacists and what type of questions you can send them. And so when you hit send message, the first time you do it, you have to put your name in, your billing number, your cell phone number, your fax number, and then you're going to type your message. And then if it's about a specific patient, you could put the demographic in, but in the case of my patient, I didn't put any patient demographic in. It was just a general question. And you can see all of that is optional for this consultative service. And then you would hit send request. And it explains what the details are there, but it's so handy. And like I say, I had a patient who'd been on a bunch of chronic narcotics, and it was seeming like maybe it's time to try methadone as a pain management strategy. I've certainly seen that work in cancer patients, and this seemed like a case to consider that. And so the FHA pharmacist called me back the next day, gave brilliant advice. It was so helpful. And I would heartily encourage you all to try that. Let's go back to the advice tab and look at some of the other advice options that are available. Gregg mentioned the pain support line. Those are the social workers and navigators at Pain BC, and if you wanted some help as a clinician in navigating services, you could send a message to them. Also, CPRI, the pain clinic, has made itself available to the whole province, willing to accept pain advice questions. They don't want to deal with the medication questions. So if you have a medication question, send it to the FHA pharmacist or to your PCN pharmacist. I felt like my PCN pharmacist in my area wasn't sure what to do in the methadone switch case, but the Fraser Health pharmacist was absolutely super helpful. So there's specific things they don't want you to ask about from CPRI, and they definitely do not want people using this as a way to check on the status of a consult. But if you have a specific clinical question, you hit send message, and you once you've put your name and billing number and stuff in, if you hit remember details, you only have to do it once. And it's super handy to be able to do that. There's a bunch of other programs that are starting to use it. It's a fairly new feature, but so pay attention to the fact that there's an advice tab, and oftentimes you can send your question to either an allied provider or a pharmacist or a consultant through Pathways. This is a really important tab, the Health Authority and Community Services tab in pain, the specialty of pain medicine. So notice up here at the top, floated up as frequently needed programs, are a bunch of the Pain BC and the Fraser Health Community Pain Self-Management Program that Jennifer Lee just told us about, and all of these great programs from Gregg. Plus there's the Oasis Arthritis Education Program I send people to all the time, and the National Power Over Pain. And maybe I'm looking specifically for chronic pain coaching support. So notice I can filter for, show me programs that do coaching support. Or maybe I'm looking specifically for chronic pain education and self-management. And here's a bunch of chronic pain education and self-management. Or maybe I have a patient who has chronic pain who would really benefit from exercise, but is too afraid to exercise because of their pain. Well, here's chronic pain physical activity. So you can see there's 5 programs that are specifically geared to helping patients with pain be physically active, including Jennifer's chronic pain self-management program, but also including the gentle movement that Gregg showed us from Pain BC, and there's some Y fitness programs as well. And then if patients are looking specifically for support groups, there's some specific support groups. So really worth paying attention to the advice tab and the health authority and community services tab in the specialty of pain medicine. Also useful, the clinician tools tab. And the clinician tools tab, over the past few years, we've started to add topic filters. Any of you who may have previously thought, oh man, Pathways has so much on it, but it's too much. We're doing different things now to make it easier to navigate, and I feel like it's like taste cornflakes again for the first time, taste Pathways again for the first time. It's, you know, we're continuing to improve it, and if you're somebody who's challenged by it, tell me today at the end of this, like what it is that you find challenging, because that's always the most brilliant input that helps us to tune it further. But so let's say I have a patient with arthritis. So I'm going to hit the topic of arthritis. And notice now it narrows it down to different kinds of arthritis. So maybe my patient has a knee arthritis. So now I have a few specific, oh, actually this is clinician tools. Let's go to the patient info tab. So maybe I have a patient with arthritis. So I've moved over now to the patient info tab. And maybe the patient has knee arthritis. So notice how now I have a narrowed selection of patient informational items about knee arthritis. Notice some of them are Pathways picks. They have a star because they're very popular on the site. So if you feel like, oh my God, there's too many knee arthritis handouts, which ones should I pick? Well, you could think about picking the ones that are picks. And you could also start saving some favorites. So for myself, I like this one, the hip and knee arthritis exercises from Oasis. I like this one, how to use a walking poles or a cane. And so I have that as a favorite. And I like this Vancouver Coastal Arthritis one. So notice now I've got 3 favorites. Some of them have a print icon. So if you're with the patient in person, the ones with a print icon are stored as a PDF and they'd be quick to print, and you could hit the quick print. Of course, you can print anything, but these are quick to print. So now maybe I want to email these to the patient. So I'm going to hit that envelope icon with the ones that are my favorites. So notice every time I hit one of these envelopes, it turns green. And now this thing called a floating modal, the developers tell me, this is a floating modal. It pops up and it starts to assemble a package of patient handouts for me. And remember I was saying I'd like that Oasis program? I think I want to add that to the bundle too. So notice how I can move from the patient info tab over to health authority and community services, and I want to add this Oasis program as well. So now I've combined things from the patient info tab and things from the services tab. The material in the info tab are static informational items like a website or a handout. The things in the health authority and community services tab are interactive programs. But this is nice because I can combine both of these things in an email bundle. So now I'm going to hit email. And you'll see that when I hit email, it opens up a sort of a preview that I'm going to be sending email links to all 4 of these to the patient. And it's going to come from a no reply email, so it does not expose my email address to the patient, and Pathways doesn't store their email address. So, we're training health authority staff around the province to use this as a way of sending information to patients from a no reply email and to save them as bundles. So notice we've got 4 together here. And maybe I feel like I don't want to assemble my arthritis bundle for every knee arthritis patient. Or I have a nurse educator working at my clinic, and they're going to always be sending the same combination of things. So it's giving me the opportunity, before I send it, to save it as a bundle. So it says if you want to save it as a bundle, to be able to email it again in future, give it a name. So let's give it a name. Knee, be good if I could spell. Knee arthritis. So I'm going to save it as a bundle, and it says after you've done that, it's going to be available for you in your U tab. So I'm going to save the bundle, and now I'll just show you if I go to the U tab. I'm doing this on Gervine's, so she has a bundle now. So you see she has a bundle here. And so in future, she could just email that to the patient quickly, or if you're working with a team and you want to share your bundles, this lets you create a URL to make the bundles shareable. And if I'm going too fast, there's in the black menu bar, see how there's this question mark help tab? So I'm just going to show you that there's training videos there. And I'd encourage you in your offices, maybe when you have an office meeting, to watch one of these training videos every week. And here's the one that is specifically about saving and sending bundles. 2 minutes well spent, I think, for everybody to learn how to save and send bundles. And then there's this 1 minute, 51 second one about how to find consultants that provide a telehealth service. And there's a bunch of other useful things. And in fact, if you go down to supplementary materials, there's some pre-made bundles. Some of my bundles I've shared here, and so if you open that up, you can see there's a bunch of bundles you could choose to save for yourselves, and there's a bunch of pediatric bundles that Dr. Kelly Cox made. So worth it to know that there's this help tab with training videos in it. So now let's go ahead and actually email this, and I'll just email it to myself. Okay. And you can include an optional message, like here's what we talked about, or one of these boilerplate messages. And then you hit email to recipient. And now you'll notice you get this yellow highlighted text at the top of your page. And if you had your charting system open, you could hit copy to clipboard, and then you could paste this message into your chart. And super handy, I always paste it at the bottom of my note so that I can ask the patient next time I see them, did you read that stuff and what did you think of it? And I tell them, I'm going to be asking you about this and I want to know which things you found most helpful. So make a point of wandering around the tabs and understanding how useful it is to navigate the site by the tabs. The other useful reason is there's care pathways that you're going to come across when you go to the specialty. So notice pain medicine has a care pathway at the top of it. So if we go to the chronic pain care pathway, the first page of it, you see, reminds us, do that conservative management that our consultant told us we should be doing first. So unless there's red flags, and maybe you want to be reminded what are those red flags again, so you can hit that, but we're going to go back up to the home page. So it's reminding us, educate the patient, because just understanding the nature of chronic pain is helpful treatment for it. And you might say, well, yeah, that's fine, but even after this session, I still don't know, how am I going to educate the patient? Well, let's hit that button. So now it's giving me a bunch of handy informational items to educate the patient. And it's giving me a bundle of them pre-made that I could send to the patient. But I'm going to open some of these up because I think nobody's going to feel comfortable sending them unless they've seen them themselves. And I would encourage you all to go to the pain care pathway and to email a bundle, this bundle, to yourself to see what it looks like to receive it and to see about opening it up. But I'm going to show you this one called Understanding Persistent Pain from Australia. And this is one that I sent to a patient who I thought, I was not sure he would be up for a 24-page brochure. It says, when something's long, we say it's what the length of it is. He hadn't finished high school, but he's a really smart guy, and he's just had a really crappy life, and part of his hand's been amputated, and he has chronic pain. And he read this, like he devoured this, and he felt so validated because it explained everything that Tori just told us about, your alarm is going off, it's not nothing. And he felt like he'd had a lifetime. And I didn't feel like I was doing that to him, but apparently I must have been, that he felt so validated when he read this. I didn't feel like I was saying there's nothing. I felt like I was saying you have something real going on, even though the scans are negative, this is a real thing. But he felt so validated when he read it, and he understood okay, I'm not going to get rid of this pain, but I'm going to be able to turn down the volume on it, and I want to understand how to turn down the volume. So I thought this is a particularly useful one to know about. And let's just go back to the care pathway. There's also the brochure from Pain BC for patients living with pain, and we'll just open that one up and show you there's, this is helpful stuff as well. And then this is a video, understanding what to do about pain in less than 5 minutes, if you think your patient would benefit from a video. And then there's one from CADIF, which is an assessment outfit that does assessments of the impacts of therapy and reviews the evidence. So this goes over non-drug ways to manage chronic pain. And the second page of it is actually like a prescription you can print off in the office, where you could recommend specific things for pain. And we'll come back to this, having a better understanding of which modalities actually have evidence to support them for pain. So let's go back to the pain pathway. And then I'll just point out, you can jump to specific conditions, like neuropathic pain. And notice how these pages are set up, where over on the right, there's evidence for treatment and what the treatment options are and what the strength of the evidence is for each. And then for myself, I sometimes forget, how do I know again if it's neuropathic pain? So there's the DN4 questionnaire you could open up to remind yourself, oh yeah, these are the characteristics for chronic pain. So now I think what I will do is we'll do the case. And the people at the table who want to contribute some thoughts to this. We have a 55-year-old male, and I think you guys have the case on your table, who's formerly a construction foreman, 15 years of chronic low back pain. It keeps getting worse, and he stopped working 3 years ago. He's had sciatic symptoms, CT scan showed degenerative disc disease, nerve root impingement. He's tried lots of different therapies. His pain regime includes cannabis, gabapentin, naproxen, muscle relaxants, T3. He sure sounds familiar. He uses tramadol, smokes marijuana to help with sleep, and he's single and has had personal loss. He's feeling helpless and anger and been having suicidal thoughts. So I guess we're going to have people at their table to talk about where would you start with this patient. And so I guess talk amongst yourselves if you want for a couple of minutes, and then I'm going to show you some things in pathways we could try to help us sort through this patient. So, or Dharm, do you want to?
Well, I was just thinking we may not have enough time to actually.
Not enough time to actually dig in and do that?
I'm not sure when are we wrapping up here.
Oh, it's true, eh? I only have 10 minutes left.
Yeah.
So you know what? Another day I'll come back and we'll actually work through a case in real time. So today what I will do is say, let's say that's the story. What I would be interested to do then is to go and look for the depression care pathway. So I would type depression path and go to the depression care pathway. Notice how any enhanced care pathways have this enhanced care pathway symbol. So let's open up the adult enhanced care pathway. And it gives us some tips, have you lost interest or pleasure? Have you felt sad or down? And it reminds us about the bathe technique, something I still use, like to sound briefly empathic. Remember B, the background, A, how does it affect you? T, what troubles you? How are you handling it? And a brief empathic statement. But also it's got the suicidal ideation questionnaire there. So if I wanted to actually assess their suicidality, it's right there in the algorithm. So that's and then you could jump again to patient information or self-management options from within the care pathway, or down here in the lower right. Are you looking for diagnostic clarification or medication advice? Then you could refer to a community psychiatrist or the mental health team, or is it support for a specific population? So each of these buttons is going to take you to the specific thing that you need. So let's say We talked about what ways to educate him about his chronic pain. I do want people to try emailing a bundle to themselves. You could even just do it on your phone. Go to the patient info tab, hit the envelopes, and try emailing it to yourself. You could even do it while I'm talking, or at least do it when you get home tonight. Practice using that emailing patient info. And then we were going to talk about what are some non-pharmacological interventions you would suggest. Well, we looked at that CADIF handout, and maybe I'll go back to it from the pain care pathway. And so if we go down to the CADIF non-drug pain treatments that work, you see how yoga, for example, is specifically helpful for back pain and primary dysmenorrhea. And mindfulness is specifically helpful for low back pain and fibromyalgia. So those are nice informational items or nice little tips about which things are going to help. Let's say I showed you if they were afraid to exercise, the other way to get to the exercise programs. One was to go to the specialty of pain medicine and then navigate over to community and health authority services, or from the care pathway to clicking on that is going to take us to those programs that we saw if we had just navigated from the specialty tab over to the health authority and community services tab, and you see the chronic pain physical activity has been pre-selected there. And in terms of his let's say he can't afford his treatment, and he would benefit from some physio and counseling. Actually, we have a new feature in Pathways where if you type a search of 3 words or more, you're going to get a generative summary. So if I type patient cannot afford, this would have broken the search, a few months ago. Patient cannot afford physio. Oops, PHY, physio, off on EI. Okay, so let's see what we get. You'll notice it says if your patient is off work on medical EI and cannot afford physio, OT, counseling, or other supports, the Reducing Poverty Initiative may be able to help. This program supports individuals with physical or mental health impairment to successfully return to and maintain employment. They get connected with a disability management coordinator, and this program is amazing. So I'm going to just open it up, but notice you could get to it just by saying what your problem was you're trying to solve. And so here's the Reducing Poverty Initiative. It's got a stupid name because it's not just about reducing poverty, although that's a side effect. It's actually a federally and provincially funded program to pay for up to 12 physios and counseling for people who are off work they need to be on EI. And these wonderful people have said, we'll take a Pathways message for your service request. So you can hit send message, and again, you put your info here, you explain briefly what the problem is with the patient. And they've said, we just need the patient's name and phone number. You don't have to get into any other fancier demographics, but just make sure you've included whether the patient's aware of the referral, what your diagnosis and prognosis are. And then they contact the patient and do the heavy lifting of getting all the details of their condition. So that's a really good one to remember, the Reducing Poverty Initiative. And like you saw, even if you forget the name, just type the situation, patient off work, can't afford their EI. Let's say the patient has, the patient told us they're drinking whiskey to help them get to sleep, and they're drinking several whiskey a day. So let's go back to the homepage and think about if this patient has alcohol use disorder, maybe what I'm going to do is go to the specialty of addiction medicine. And I'm going to be opportunistically shown, hey, check it out. There's an alcohol use disorder care pathway. Pathways has an agreement now. We're working with the guidelines, the Provincial Guidelines Committee, and they're beginning to embed Pathways in all of their work. So here it gives us, a basic question, like how many times in the past year have you had 4 or 5 drinks in a day? And so you could either use the click in here to get to the audit test to do it yourself, or you could email it to the patient here if you want them to do their own audit self-test. And then it helps you run through the various, approach to treatment. And then maybe you're looking for rapid access. What are my local options? You open that up, and it's going to take you to rapid access options for accessing addictions treatment. Or maybe you're looking for mutual help groups. There's AA, Smart Recovery, LifeRing. Maybe you want to email all of those to the patient, because AA is not for everyone. And so when I send it, I send a bundle of, you could choose LifeRing, you could choose Smart Recovery, you could choose Find an AA meeting. A booklet that I just love for these patients, and that I would say after 30 years of being completely incompetent at trying to help anybody with an alcohol use disorder, some of the patients managed to get over it themselves, and they credit me ever so slightly, and I feel like, man, you did it all yourself, because I do not have a great skill at this. But this booklet actually made it possible for some of my patients who have been trying to encourage to drink less or stop for like more than a decade. And I tried, once I learned about naltrexone, to get them to take that, but they wouldn't do it. But now with this booklet from RX Files, it's a nice one to open up in the middle of the visit, and we look at it together. It's got nice pictures, and some people might not be that interested in hearing about the risks. They all seem interested in tips for drinking less, because it sounds like I'm being less judgmental. And I say things like, change from your favorite drink to one you don't like, which is kind of amusing to people. But it's like, oh yeah, or make a rule never to drink alone, or avoid rewarding yourself with alcohol, or try to have a glass of water. So it feels low barrier for them. And then this talks about how medication can help. And this Mark's story was the thing that got this patient of mine last month, who I had written a naltrexone prescription, 4 times in the past year, and he never fills it. And he's like, I don't really believe in medication. I think I could do it myself. And anyway, we read this together. And this guy explains, I'm not really a med guy, but I wasn't fighting with myself not to drink anymore. And when I did slip, I didn't enjoy the drinking. It helped me get on track much faster after the slip. I'd put years of work into recovery. Naltrexone allowed me to actually apply those tools. And I'm a person who's scared to take medication, but I was desperate and I didn't have side effects. But honestly, even if I had side effects, I think it would have been worth it for me. It helped me get my life back on track. And so it's so great to have a script, right? And to sit there and read it together, and then click the email button on the item and send it to him to read after with his wife. Or you can print it too in the office. But it's been a game changer for me, and having the words written in a thoughtful and good way, just makes such a difference. And sometimes, I don't know if this has ever happened to you, but sometimes I told a patient something 10 years ago, and they come back and say to me, Dr. Monk, I remember 10 years ago when you told me blah, blah, blah. And I've said it to myself every day for the past decade, and I'm like, oh my God, I'm not even sure that's right. I got to be careful what dribbles out my mouth. And so I love it when there's something like written down, and I know I could use this, and it leaves me feeling like maybe I'm slightly competent. Maybe I can actually do this. And it's really felt wonderful to make progress with patients who have had alcohol issues. In terms of sleep, if the guy's using it for sleep, obviously looking for sleep hygiene materials would be good. And so there's various sleep hygiene things that are popular. And let's say he didn't speak English and you needed a translator. And to get the provincial translation system, there's a specific code that you need to give to the system to get the translator. So you could type into Pathways, Surrey translator code. Let's see if it works. For Surrey-North Delta offices, access code for primary care interpreting services is this number, and the phone number for provincial language services is that number. So you would call the language services and give them 3765, and you're going to get your translation services. There's a million other things I'd love to show you, but I think we're already at time, and so I would probably need to come back another day. But the idea is to definitely try playing with these things yourself and send information packages to yourself. And maybe I'll come back another time and you can tell me what things did and didn't work and how we could continue to tune pathways. All right.